Good morning, Commissioners. My name is Susan Wheelan. I serve as the Director for your Public Health Agency. And I wanted to start off with some brief information about the people that are working behind the scenes prior to getting into some of the data and what the future looks like with Dr. Kelly. There are numerous staff and community partners that are working behind the scenes, and I wanted to highlight some of their efforts and take a moment because we've been in this COVID response. We've been monitoring it since 2019, late 2019, but it's only been about a month since we've have been responding, and there has been some incredible actions, not only by the emergency response staff, but also the community. Emergency preparedness and response is a key priority for public health. Part of preparedness is having plans and testing plans with partner agencies. We began developing numerous preparedness and response plans after 9/11. All staff are required to complete incident command system training and emergency preparedness training during the first 3 months of hire, with the rationale that any employee could be activated to respond to a public health emergency outside of their normal duties. We conducted numerous exercises such as the 2017 FedEx, and that's a play on words, public health exercise and dispensing. The focus was on distribution of the national strategic stockpile. We tested our ability to get supplies to the regional partners and at the same time to local partners. That is just one of the relevant exercises and is also important about our abilities when we have a vaccine and hold points of dispensing for clinics for the COVID response. Our communicable disease and emergency preparedness staff, which includes about 10 people, responsible for monitoring, limiting, and stopping the spread of more than 60 reportable diseases, one of them being COVID-19 in El Paso County, and our emergency response staff are responsible for the South Central region of Colorado, which includes El Paso County, Park, Lake, Chaffee, and Teller counties. They have been monitoring the situation since late 2019 with the South Central Health Coalition and helping lead this response. To mount a robust, sustainable response to COVID, we folded in additional staffing totaling about 80 members of our about 160 staff. Wanted to reiterate that we have 80 staff that have not been part of the emergency preparedness or communicable disease team that are folded into this response to ensure that we have a robust response. Also, as part of the Pikes Peak Regional Office of Emergency Management, there are upwards of 150 teams and staff that are working on this response. And I wanted to highlight that because a lot of times you're seeing me up here, or Dr. Kelly or Dr. Johnson or others at news conferences, but there are folks that are working tirelessly on this response 24/7. And I think that that is extremely important to note because there are a lot of experts and dedicated people that deserve some recognition in this all-hands approach. A few of the areas that public health is continuing to focus on is the planning and response. Public health has been leading the charge in organizing partners, including those from...
Can I stop you for a second?
Sure.
I'm getting some text messages that we can't, that some folks can't hear on Facebook Live. Blake, is there a way we could troubleshoot that quickly, please?
Sure. I have checked our Facebook Live, and I am hearing Susan on there. So,
looks like it's working. All right, sorry about that. Please proceed, Susan.
Okay, thank you, Commissioner Waller. The key areas that public health focuses on is planning and response, which we're in the thick of it. And with the Pikes Peak Regional Office of Emergency Management, we have unified command, and there is a emergency coordination center, which our Deputy Director, Deanne Ryberg, who is a public health nurse, serves in that role. As incident commander, we have an epidemiologist who serves the South Central region, Marion E. Klaber, and we also have Robin Trujillo, who is a public health nurse serving as incident commander and changing out. I think that's important because with different types of emergencies, floods, fires, you don't find a public health nurse that typically is going to be leading the charge. But with this pandemic, we do have public health staff, public health nurses that are assisting with the overall operation, but more importantly, leading the charge with the whole operation. We also focus on disease control, working around the clock 24/7 to investigate and do some contact tracing, and Dr. Kelly will get in a little bit more of that, but there have been hundreds of investigations, and these folks continue to evaluate the different clusters and to lead our different efforts for our community. We also have some exciting news to share with our data analysis and research team. They have been working to evaluate what's going on in the world, what's going on in the state, and also what's going on locally. The information that you see in Dr. Kelly's slides and presentation, that was the work of our Public Health Data Office, and they have put together different models for us to have a better understanding of what's going on in El Paso County. We will be launching a data dashboard this week for the public and also for the media to have easy accessible data for El Paso County, and also comparisons as to what's going on with the COVID response around the nation and the state and locally. We also have a robust communication team, the Joint Information Center, with a lot of phenomenal people from the City of Colorado Springs, different municipalities, our office, Public Information Office, and other nonprofits that are helping out and doing daily updates, providing information not only through social media, website platforms, but also relaying information to the media on a routine basis, and that occurs, I believe, every day at 1 p.m. And when there's significant information to be updated, then they use different tactics to get the information forward. We educate partners and citizens, businesses about the etiology and epidemiology and appropriate standards of response to the COVID-19 response, and we've been doing that all along the way. The area that I think is extremely phenomenal is the collaboration in the community. These are people that are not only invested through their organizations, but they have the biggest hearts. They are so passionate about taking care of folks in the community, and a couple of those organizations are the Pikes Peak United Way. They are providing staffing for all of the call centers, and I want to say it's upwards of 40 people answering the calls and being responsive to the community with their questions and concerns. They are also organizing financial assistance to residents, and also have set up a community foundation emergency response fund. There are numerous different funders that are joining the cause and providing different funding for different sectors within the community. The Pikes Peak the Pikes Peak Regional Office of Emergency Management has been helping us facilitate the personal protective equipment, the PPE, and helping us facilitate the receipt of the National Strategic Stockpile, and the amount of work that goes into that as well. It comes on pallets, and we need to have people that break it down and sort it, and with the masks, that there's over 300 people that are in the community that are sewing masks. You know, what's involved in that is that they come to the OEM, and they have to be laundered and then distributed. So there's a number of different logistical types of efforts that are happening, and again, it's phenomenal what has been happening over this past month and how everyone has been coming together. There's a lot of need for local food assistance. The Salvation Army, Cause I Love You, a number of churches and faith-based organizations have come together to help out, and the CARE and Share Food Bank, the Colorado Springs Fruit Rescue, and Silver Key, providing a variety of food assistance programs to those in need and the elderly. This is not an all-inclusive list. There are a number of organizations that are not on here that are working tirelessly behind the scene to help our community out. A significant highlight is the FEMA testing site that was set up by UC Health and Public Health, and also numerous others that was recognized by the White House, and expanded testing for high-risk populations, including healthcare workers, first responders, and those over age 65, and that will be a site that will be continuing to test. Others have joined in the response. The coroner's office, the majority of their work is centering around COVID-19 and the response, the investigators, Dr. Kelly has stepped up and is serving as our Deputy Medical Director to expand our capacity. UCCS Bethel College of Nursing, they have 35 students and 5 faculty members that are going to be helping us out with the epidemiology investigations, because we feel it's important that we do contact tracing and that we stay on that. And so with all of those folks that are working on the response, I want to thank them for their dedication and the passion. One more slide with collaboration is the Homeless Isolation Center that we worked with City of Colorado Springs and the Community Health Partnership, Springs Rescue, and others to make that happen. And multi-sectors within the community, local schools. I think it's incredible that schools are, everyone's had a hard shift, and the way that we're living our daily lives and the way that we're accomplishing our work are the ways that we are educating our children, and to offer the e-learning and providing the technology tools and learning from home, and reaching out for to provide free meals and to students is phenomenal with time that we've had to put all of this together. The business and employment resources, the Pikes Peak Small Business Development Center, the Colorado Springs Chamber and Economic Development, and the Pikes Peak Workforce Center assisting local businesses and individuals with coaching, financial assistance, and employment services. These are just a few of the highlights that I want folks to take note of, because although you don't see them front and center, we've had to change our operations. For example, with the Pikes Peak Regional Office of Emergency Management, the majority of folks are remote. And normally, Dr. Kelly and I are also remote from our home, so we're not coming into the office to follow the stay-at-home order and do our part. But these photos right here encompass some of the dedication and the work that is going on in the community, not only to respond to the COVID disease, but also to help the community out, because there's so many different impacts that are happening in our community, and we're going to be in this situation for a while. And Dr. Kelly is going to talk a little bit about that, what the future looks like, and what help we're going to need for the community as we think about and as we relax some of the restrictions to navigate through this unprecedented pandemic. And with that, Dr. Kelly, would you please come up? Thank you, commissioners.
All right. Thank you, Director Wheelan. Thank you, County Commissioners, for letting us be here today to present to you where we are right now in our COVID-19 response, as well as where we're going. In the overall gist of what I'm going to talk about today is that while this challenge has been, monumental, and the tasks have been many, we feel from the public health perspective that from the first time that this fight started, we are winning and we are in a good place. The victory is not yet ours, certainly by no means, and we've got a long, continuously challenging road ahead. But I think we're in a place now where we can begin to have those conversations about where we go next, what that looks like, what we really need to do to finish this thing. And so that's where we're headed today. So let's start with numbers. El Paso County, 665 confirmed cases. 39 deaths currently. Colorado there, about almost approaching 8,000 total cases with 308 deaths. The United States there approaching 600,000 cases and a little over 23,000 deaths. And then globally, approaching 2 million cases with nearly 120,000 deaths. And so we'll start with some data, and once again, all of this is being generated by our own Office of Data Analytics, with the exception of one slide I have in here, which is from the Colorado Department of Public Health and Environment. And so let's start globally and see how we're doing. And here is a dot graph showing various countries around the world. The x-axis, the one across the bottom, is deaths per 100,000. We talk a lot about raw numbers, but raw numbers don't mean a whole lot without the context of rates, because every community's got different numbers of people, every country's got different numbers of people. So if we really want to more accurately talk about how folks are doing compared to other folks, this is really the way to do it. And so deaths per 100,000, you can see is across the bottom, and cases per 100,000 is across the y-axis there, kind of going up. And you can see where the United States stacks up. One of the other things to note is that the size of the dot itself is the total number of deaths. And so as we all know, this week we eclipsed all other countries in the total number of deaths. But when you look at deaths per 100,000, the United States is still towards the left and doing better than many other nations, such as Spain and Italy and France, who were hit incredibly hard. One of the important key points to note, though, is that's New York State up there in the upper right-hand corner. And I think most of us who are following this from a national standpoint know the fight that those folks have had on their hands from the very, very beginning. Obviously, the New York is also included in the total numbers of the U.S. there. But this is a very sobering look at what happens when this virus gets out of control very quickly and beyond what your ability is to deal with it. And that picture right there is essentially what the rest of the country is trying to avoid. And much of our federal resources at this point, while it is going to other places, including Colorado, it's going to the place that needs it the most. And right now, that's New York State and much of the northeastern seaboard states. Moving on to states that are nearer to us. These are all many of our adjacent states. Across the bottom there is tested per 100,000 people. Obviously, it's a number you want big, so we want to be far to the right there. That means you've tested more of your citizens. And Colorado, while we certainly are ahead of many of our close neighbors there, we are not leading the pack. And then cases 100,000 is the y-axis there going up. That's a number you don't want to be up at the top. And unfortunately, we are there. So we do have, of the people we have in Colorado, we have a relatively high percentage of people testing positive. And then the size of the dot there is deaths per 100,000. Also, you want to be smaller as possible. So Colorado, while we have made significant progress, we have fairly large cities, including Colorado Springs and Denver and Arapahoe County and some other folks. And so we have certainly had more than our fair share of cases, and then unfortunately the consequence of those cases, which is our deaths. And now we're going to take a look at El Paso County specifically, and then compare that to some of our neighbors. Total number of cases is across the bottom there, and then population is going up. And so when you look at our population, which is essentially identical to Denver, very close to it, slightly more folks here than Arapahoe County, our case numbers are below those, and our total deaths, which are the size of the dot, is less than Denver, pretty close to Arapahoe, and then less than Weld County. Early on, we had a large, very high death per case number, and we talked a couple weeks ago about why that was. We were hit in our most at-risk community right out of the gate, which caused our fatality numbers to jump up. And I said at that time that undoubtedly over the next few weeks those numbers would come down as the disease progresses through the more general population and less of the at-risk folks, and that certainly has been the case, and that's what's happened. And so El Paso County, here are our numbers over time. We had our first case on March 5th there, and then we had a lag, and then we had obviously increasing numbers of cases over time, and the blue are the daily case increases. The orange is the overall increasing number of cases. Obviously, every case you get is going to add to that. That number is never going to go down. But this gives an example of where we're headed this week as far as our ability to communicate with the community. This is a snapshot of the dashboard, the public health dashboard that will be unveiled and launched here in the next couple days. And this will give our citizens the chance to see how we're doing day by day, as well as over short periods of time, and then kind of examine things across different demographics and things like that. That'll really help not only the community, but also the media see where we're going and what we're doing. And so that's some of the things that we're pretty excited about, being able to communicate better with the community and get that information out. And here is our age ranges, and I presented this a couple of weeks ago with hospitalizations and deaths, but this is the breakdown by the decades. And we noticed a couple of weeks ago how dramatically different our demographic looked than Colorado in general, and that's because we were having large numbers of cases, hospitalizations, and deaths in that high-end age group. And this has also come down as we increase testing to other demographics. Once again, at the beginning, we were testing only the sickest, and so it's not surprising that the people who were testing positive were only the sickest. And so now as we've been able to expand that testing beyond those inpatients and people that were critically ill to other age ranges as well as groups, our demographics there are starting to match more of the rest of Colorado. Colorado Springs, or El Paso County, is one of the higher counties for older folks, and so that puts our community particularly susceptible to spread by this disease. And then when we look at the average age of cases, now 53, average age of hospitalization is almost 67, and then our average age of death is about 78. And this fits what we've seen in other places. The older you are, or the other conditions that you have, the more likely you are to do poorly, end up in the hospital, and then die from the disease, and that's what we're seeing. This is new data.
Hey, Dr. Can I stop you for just a sec?
You bet.
Commissioner Brimmer has a comment.
I'm sorry, I didn't mean to interrupt. I just wanted to say thank you for the development that's gone into that dashboard, the creation of that. I believe that will go a long way for transparency and providing the reasons behind why we're asking our citizenry to do what we're asking. So just thank you for the work that's going into making that a very public and somewhat interactive tool.
Yeah, thank you. And you're exactly right. I mean, that's the goal with getting this information out there. It's one thing to have information. It's another thing for it to be usable and presented in a way that average folks can learn something from it and do something with it. And so that's really been our focus, is giving the community meaningful data, meaningful statistics that don't panic people, but allow them to understand kind of what's going on and what we're doing and why. So thank you. And so this, like I said, this is new coming out, and this is cases by zip code. And this should surprise no one at all that, the place where we have the most people are the places that we're seeing the highest numbers of cases. But it should also illustrate that this isn't just a city problem. This also affects our rural, in addition to our urban areas, our rural areas. And that's the breakdown generally of El Paso County there on the right, that pie chart. The other are some of our other communities, and some of which may only have one or two cases, and so we didn't specifically break those out. But this information will also, as we progress through this and we build more numbers, this data will become more robust as well. And then here's one of the other things that we're doing this week. We've started transitioning to talking about recovered individuals. And we know that the overwhelming majority of people are going to do well. Some are not going to do well, but they're going to get better. And so that's important data to communicate. And both statewide as well as locally, we're starting to look at that. Right now, we're mathematically calculating that. If you haven't passed away and you're not still in the hospital, we're assuming at this point that you are recovered. But starting probably mid-April, as we have more individuals to reach out to, and more people fall into that mathematic category of not hospitalized, not deceased in 14 days past the time that you were diagnosed, we will begin calling these individuals specifically to talk to them about how they're doing, confirm in fact that they have gotten better, and then to interview them about what that experience was like. Is there anything that we're missing, maybe symptoms that haven't been previously reported? Kind of getting an idea from the folks who have done well with it, what that experience was like, that can help us educate and inform other individuals moving forward, maybe increase our sensitivity for diagnosing and picking up people that we need to get tested and that kind of thing. And here's really the most important chart I'm going to show today. And this is our El Paso County local hospitalizations. And this is what essentially success looks like. This is what a flat curve looks like. And I think we've all heard that phrase, what is probably 1 million times at this point. But this is what we've been looking for. And these are the folks, this is hospitalization. So this is independent of how many test kits we have available, how many people we're testing. This is a true, meaningful number. At the end of the day, this is what we are trying to do. Keep our hospitals with the ability to treat the people who are sick, right? So the number one issue is how many people are showing up at the hospital with this. And you can see in the very beginning, over that March 13th through about the 19th, 20th, if you draw a line right there, what that trajectory looks like, it's nearly straight up. And that's what unmitigated, uncontrolled spread looks like. And as we talked about a couple weeks ago, when we look at data, we look at cases and hospitalizations, whatever is happening today is really a reflection of the virus activity a couple weeks ago. And so we're always looking kind of in the rearview mirror. And we know that trajectory from the 13th to the 19th there is what spread looked like from the beginning of March through the first couple weeks of March. And if we had continued on that trajectory, that would be a doubling time, meaning one case becomes 2, 2 becomes 4, 4 becomes 8, which is exponential spread, which is the key thing we are all trying to avoid. That doubling time of probably close to 1 to 2 days, which is really catastrophic. Once those early mitigation strategies go into place, the early social distancing things, you're going to start to see a little bit of an effect. And that's what you see from that March 19th through, let's say, the 27th. Some of those early efforts that we put in place, the hand washing and the social distancing and the smaller group sizes for events, that's the effect that you're going to see there. And then our much more strict social distancing, essential workers only activities come in, and that's when you see that really flattening out of the curve. I mean, to this point, that's approaching horizontal. That's a doubling time of well less than 12, 13, 14 days, which is what you need to do to slow the spread of the virus and to maintain the healthcare infrastructure. And so this is a good snapshot of what no action looks like, and Commissioner Vanderwerf made a good point a couple of weeks ago of what our early projections on hospitalizations and deaths, and all of those were based on us doing nothing. Well, of course we weren't going to do nothing. That would be a nightmare approach. And this has been repeated in other places. There's a really great study that came out of China within the last couple of weeks, where they took communities and then they looked backwards and said they had 5 stepwise ratcheting up of restrictions. And as they did that, you could see very clear, statistically significant alterations in the spread of the disease. And so this is what we've been asking the community to do. This is what they have done, and we are seeing the effects of that. This is what we needed to see to begin that conversation about where we go from here. And I showed these graphs a couple weeks ago now with just some more data. The one on the left is Colorado. This is cases and hospitalizations. So blue is going up. That's the case number. Once again, that number is essentially always going to go up because it's just adding on to the total number of individuals. The orange is the number of hospitalizations, and then the gray is the percentage of those cases which become hospitalized. And remember, we talked kind of right out of the gate how we had quite a few people in the hospital, and as we've gone over time, the Colorado in general has steadily increased. Ours shot up to our peak there around March, the end of March, and is now starting to come down. And those numbers will likely continue to flow closer to one another. I would love to see that number obviously come down, and as the hospitalization percentages and as we start to test less at-risk populations, which we are doing now, that number will continue to decline. And so now we get into what the plan is moving forward. And the goal is to go ultimately from these broad community-wide interventions to more focused, more tactical, more surgical interventions. And that's where the contact tracing comes into play. And I went through this last time talking about the bridge tournament, but I want to go over it again because I think it's important, it's critical for folks to understand what our key weapon moving forward is going to be once we start releasing some of these restrictions that we're currently under. And so the way that this works is we have a positive test. A positive case comes back. Someone is ill, they show up to the hospital, or they show up to a testing center, or they show up to their doctor. That test comes back positive. We know that person has COVID-19. We're going to reach out to that individual, find out who that person came into contact with. We're either going to reach out to each one of those individuals, find out whether they are symptomatic or non-symptomatic. If they are symptomatic, meaning now they likely have it, we're going to test them. And we're also going to isolate them. We're going to make sure that they are not around other people who they could potentially infect. And if they need treatment, we're going to give it to them. All right? If we reach out to them and they are not symptomatic, they're feeling quite well, we're going to say, hey, we know you've been in contact with an individual with it. You are at very high risk of developing symptoms yourself. We now know that you can pass this disease on either while asymptomatic, meaning you don't ever get sick, pre-symptomatic, meaning you're not sick now, but the next couple days that you will, or that you're minimally symptomatic, meaning you think you feel pretty good, but you got the little sniffles. I'm sure it's just seasonal allergies, but in fact it's not. It's COVID. And so that person is going to go into quarantine, meaning we're going to say, okay, you're at risk of having it. We can't have you passing it on to anybody else. You're going to stay home for the incubation period, which is the 14 days. Okay, the person there, the third one on the right, is someone that we didn't know they existed. The person that we initially contacted didn't know. They went to the grocery and they touched something and someone immediately touched it after them and contacted it. We're not going to know that person, so that person's going to continue possibly to spread the disease to other. That's where the current social distancing comes in. Okay, we're going to assume everybody potentially has it, and so we're doing that. We're going to essentially at some point in the future move away from that, and that's the approach that we're going to take moving forward. All right. That's still what we're doing to this day. We're focusing predominantly on our high-risk individuals, but as we build capacity as Dr. Wheelan said, we are able to reach out to all these people. This is important because as we continue through this and as we begin to release restrictions on the movement of people, this is going to be our number one weapon to prevent further spread, to prevent exponential transmission that we saw early on. And this is going to allow the rest of us to kind of get back to business as usual, but continue to keep a lid on the virus. And the way that we're going to do that is by building the capacity of the public health department to have enough folks trained in this so that they continue to do this. And that's what Director Wheelan spoke to earlier about bringing on the UC health nurses and other folks. So we feel like we're in a really good place with staffing, that we are going to be able to more robustly continue to do this. The reality is as you release restrictions, it is guaranteed that this disease is going to spread. That's just the reality. And so our cases are going to continue to go up. And that's okay, right? There doesn't need to be panic that as we open things up, that cases continue to happen. As long as we have the ability to control it, we're going to be all right. What we don't ever want to have happen is that we have events of transmission that get it out of control so that we can't use these containment strategies. And that's what we're going to do. At this point, we control the spread of the virus based on how we're mitigating it. We are now driving the bus of who gets the virus and how quickly it spreads. All right? And we always want it to stay that way because we do not want to have to ratchet back down if things get out of control. And so it comes to the key component of how we progress from here, and I'm going to talk a little bit more about it, is that it has to be done in a stepwise, thoughtful, managed way. It's like turning on a faucet, right? We turn it on, and we control how much of that comes out. We don't ever want to let that tiger out of the cage again, all right? And so this will not be a ticker tape victory parade, let's all get back on the street. That's how we lose control of this thing and end up where we are now. And so we'll have a very clear plan with State Public Health Department, with obviously the governor, and then locally about where we're going and how we're going to manage this and make sure that we can do this responsibly. Part of that, the big part of that, and this is a key component, is testing. We need to be able to identify those individuals who are symptomatic, get them tested, and get those results back in a meaningful time span that allows us to make those clinical decisions. We lost that ability in this fight very early on because of delays in testing and poor access or critical shortages of testing, which is one of the reasons we had to go to Plan B, which was the mitigation strategies. And so as we move back towards this more focused approach that will allow us to get some of these things back open, we need to have the testing, and this is what has happened locally. You can see the gray there is the CDPHE lab. When this all started, CDPHE's state lab was really the only game in town. Very quickly, commercial labs came online, and as you can see over time, those are the green. The commercial labs has essentially eclipsed largely what CDPHE is testing. That's a good thing, because that means we have capacity at the state level, and now we have capacity at some of these private labs, and we are working daily to sort out what tests are available and where people can go, and managing those turnaround times and making sure we're diverting people to the places to get tested and to the labs that allow us to make these decisions as quick as possible. So this is one of the areas we've had the biggest gains over the last month. But we will need to continue to focus on if we want to step back some of these the big population things towards a more focused approach. And so what does this look like? And now there are several really good public health think tanks and groups that are coming out with what we will do to come back out of this. And the good news is, as I talked about a couple of weeks ago, America was fairly late to the dance on this one, which allows us to see what other countries are doing. China, within the last couple of weeks, has already opened things up. This week, there are multiple European countries that are opening things up, and we will have the opportunity to see how they're doing and what they're doing and what's working and what's not. And so this will be something that we continue to evaluate. So we've broken it up, and this is based on that group there. There are several now are very similar, but we're using this one. This is the novel coronavirus response, a roadmap to reopening. So we got 4 phases. Phase 1 is slow the spread. That's where we are now. That's where you have your exponential growth. The thing that you're trying to do is just slow the transmission from one person to the next, so that essentially you can survive the surge and the peak. And that's where we are. Second is going to be to reopen. This is going to have to be regional. It's going to have to be locally driven by data and by what's happening. Some places are going to be in really good shape. Other places are going to stay under fairly strict procedures and approaches for a fairly long time. Phase 3 is establish protection, and then you can lift all restrictions, and then phase 4, we're going to go through this. So phase 1, once again, slow spread, that's where we are. That's where when you have community spread, usually when you have doubling times less than 5 or 6, that's exponential growth, and you're not going to be able to sustain that without putting measures in place. The techniques are largely population level controls, and that's what we've been doing. And then social distancing, that's how we've stopped it, and that's the main tool that we've used, and we've been successful in that. That technique obviously doesn't come without significant cost, economically, socially, mentally. It impacts every aspect of our society. And so the goal is to get through that phase, get it under control as quickly as possible, and then build up your capacity so you can move on to the next phases once it's safe and you can control the spread, as I talked about. The actions, the purposes is save lives, prevents from spreading to those at-risk populations, build capacities, testing, hospital capacities, and our ability to track. Those are the tools that we're going to need to move forward. And then learn about a virus. As we talked about, this was new. And early on, a month ago, there were many things that we didn't know that we do know now. And we've had to react to those changes over time. And we continue to learn more. And so phase 2, and phase 2 is where we want to be headed, which is reopen. Has to be done deliberately and incrementally. We have to be smart about this. We have to make changes and then evaluate how those changes are working. Once again, we never want to lose the ability to control the virus, because if we do, everything we've done to this point is lost, and we have to take a huge step back, and we don't ever want that to be the case. Controlled spread is where we are headed, and we will continue to see over the next couple of weeks as the stay-at-home orders are in place. That should give us the time to really see where we're doing with our case numbers. As we increase our capacity to test, we'll be able to see how the community is doing. We'll continue to monitor those hospitalizations and how those hospitals are doing, which they are doing quite well currently. I feel like all the hospitals are very happy with the place that they are, which is very encouraging. How do we do it? How do we move to phase 2? Once again, we revert back to those more surgical, precise ways to control the virus through that contact tracing and testing. We feel from the public health perspective, we're in a really good place with staffing and training and surge flex staffing that we can do that. And then is when you are allowed to reducing some of the social distancing. In most countries that we've seen have done this so far, kind of start with their schools, their least at-risk population, which is our young people, opening up some of those critical businesses and the things that allow us to get the economy as well as society back to going strong. And then actions from that point are begin a step-by-step return to normal. This is, once again, not an overnight mission accomplished situation. These efforts are going to continue for some time, and this is a framework. This is not a timeline. There are many things that have to go into this, including what our state and federal government are looking towards. But the reality is during that stepwise progression, you start with the people that are least at risk. You start with the people that have maybe already had the infection and are doing well and have recovered. But you remain those high-risk populations sheltered. And so we need to continue to support our long-term care facilities and our older folks and our immunocompromised individuals, because the virus will still be out there. It will still be spreading. It's a controlled spread as opposed to what we started with. Once you feel satisfied with where you are with that, you can begin phase 3, which is to lift all restrictions. The reality for phase 3 is you need one of a couple things. You either need effective therapeutics, meaning you have drugs, medications that either you can use to prevent the infection as a prophylaxis or treat the infection. And as of this very moment, we do not yet have clinically validated medications that have been proven to increase survivability or decrease symptoms. There are numerous clinical trials in place. Some of those have been encouraging thus far. We do know some medications in a laboratory seem to be effective at reducing the virus's ability to enter cells. So all that is very encouraging news. And hopefully over the next few months, we will have more definitive evidence that some of these things are truly effective. The other thing, which is really the game changer, obviously, for any infectious disease, is vaccines. And there are several clinical trials happening, several different routes of creating a potential vaccine. But that weapon is not going to be here still for some time, probably not until next summer, or possibly even later. And so that doesn't mean we have to stay sheltered in our homes until then, but it does mean that once we get to that phase, essentially all of this is buying us time until we get there. At that point, case level controls. This virus is going to be with for a while. Even with a vaccine, it takes time to roll out a vaccine. You start with the most at-risk people, and then you kind of move from there. But at that point, you have essentially the ability to control the virus and control those folks who do become infected. And then actions are going to be obviously to deploy those medical interventions, which is going to be a worldwide deployment, and we can return to normal social gatherings. Until that point, there may be situations where some things are still not allowed to happen that involve large groups of individuals. And so once again, this is going to be stepwise, and it's going to be thoughtful, and it's going to be data-driven. And then lastly is, how do we make this not ever happen again? Diseases are always going to be with us. That's the reality. The only thing that we can control is how we respond to them. And the best way to respond to them is not with population-wide damaging effects, but to do so in a way that we can predict what's coming, monitor those things, have testing available when they do come out, and be able to generate and engineer vaccines and treatments at a much more rapid pace. And so there will be a lot of time to look back on what's happened here and how we've handled it, what we did great and what we could have done better. But this event will likely change our perspectives on many things, the same ways as World War II and the Great Depression and 9/11 and some of those other foundational events that the country and the world has dealt with, that we come out as stronger and with a better plan to prevent those same things in the future. And so with that, I think I am done, and so Director Wheelan and I are available for questions.
All right, I know Commissioner Vanderwerf has a question. For my other colleagues, if you have a question, just let me know in chat, please.
Thank you, Mr. Chair. Fantastic briefing, Susan and Leon. I appreciate it. And so, Susan, just quickly on your side, and then I'll go over to Leon. I just want to express my thanks to all these organizations that are participating in this, the Pikes Peak United Way, the 300 people sewing masks, the Springs Food Rescue, Silver Key, and UC Health. I mean, that's just really outstanding. And Leon, on your side, I think this data is great. And I hope that other places are doing this as well. The state is doing it. Maybe at the federal level, they're doing it. Because with that data, we'll be able to start assessments about what government response actions were more or less effective. I was kind of like trying to do my own just by looking at the chart about when we started to stay in place and when you started a leveling of the curve. And then from that, you can possibly get some insights into whether stay in place did a lot or didn't do a lot. And I'm making no opinion of it at the moment. I'm just simply saying the data can help us inform us about what may or may not be working. And then I think that can also be done in things like social distancing, going from in-store restaurants to takeout restaurants. If you're sick, stay at home. And then I really like this concept of contact tracing, because that when we see something, that gives us this opportunity to possibly quarantine or do something very specific to an identified case, while allowing other parts of the economy that does not seem to be affected anymore to go forward. So I just think that's really great. I think your 4 phases are great. I would encourage you to continue on. And I think there's a lot of possible things that are way above my pay grade that the scientists and doctors can maybe work on. But I've always wondered, is there a way to do environmental intervention? And what I'm talking about is some type of ability, some kind of machine or box or something that could go into a room, into a restaurant, dining hall, for example, and actually identify what kinds of viruses might be in there so that we know if we have a contaminated place or an uncontaminated place. But that's the kind of innovative thinking, plus the other things that you mentioned, that I think is going to get us out of this and get the economy back up and going. So I just want to thank both of you guys for that and keep going with it. Appreciate it.
Thank you.
Thank you, Commissioner Vanderwerf.
All right, I know Dr. Kelly's going to get over to City Council. Any other brief question for him? All right, seeing none. Thanks, Dr. Kelly.
Mark,
appreciate all you're doing.
The DA would like to make a comment.
Oh, go ahead.
Yep, District Attorney.
Yeah, Mr. District Attorney, if you could come down to the microphone, we can't hear you.
I just had a question of Dr. Kelly. He and I have talked a little bit about jury trials. I have 6-person jury trials and 12-person jury trials. Where do you think we are on that? I know the judges are watching you today because currently we've canceled all jury trials through about the 24th of this month, which is that Friday, and we're kind of curious where we're going to be late April, May, and what precautions we might be able to use to still have jury trials, such as masks and other things.
I think Diana May wants to weigh in on that. Diana, go ahead.
District Attorney May, I'm happy to have that conversation with you offline. We've been working with Dr. Kelly in the courts on that. And I'm happy to provide you the updated information that I think I had provided from Friday. I do know Dr. Kelly does need to get over to City Council, and I'm happy to coordinate that information with you.
Yeah, so I think that does illustrate a good example of kind of what we're talking about. This is not going to be business as usual for a very, very, very long time, but we do need to get back to business, and there are going to be ways that we are going to have to figure out how to do that in ways that are safe, that are still in the spirit and medically sound of preventing spread, but allow us to continue to do things. And so those conversations will continue to be ongoing, and there are going to be ways that we are going to be able to continue safely and begin to come out of this in a way that allows us to effectively do our jobs, but do it in a way that we can still control the spread. And so all of that stuff is going to be happening, and really, in every conceivable business and phase of the economy and government and everything. So we have a lot of challenges left and a lot of things to figure out, but we're, for the first time, I think we can walk out of this room feeling much better than when we came into it. So it's good things.